Bismillah ar-Rahman ar-Rahim. This is yet another lecture on medicine in the tropics. We have started discussing hematological diseases in the tropics, and we started with anemia, a very common condition which affects the 85% of all anemic patients in the world are in Africa and Asia. We dealt with that, and this lecture will cover sickle cell disease. Sickle cell disease. And this is again a very common disease in Africa. It's estimated that 25 to 35% of Africans have the gene of sickle cell. It's an autosomal recessive gene, meaning that a patient, to be a patient with sickle cell disease, has to have a gene from the mother and a gene from the father to give him an SS, what we call hemoglobin SS, and that is disease. This is the disease itself. But if he is a carrier, it will be AS, that's heterozygous. And a patient who is married to carrier parents married, they can have a chance of 1 in 4 of breeding one patient full SS. So this is an important disease in Africa, and I think one of the most important hematological disease in Africa. What happens? Genetically, there is a mutation in the codon, mutation of the codon of the B globin gene. So the mutation of the gene which controls the B globin. And what is codon? Codon genetically is a sequence of 3 DNA or RNA that corresponds to 1 amino acid. So if this gene mutates, then an amino acid will be in an abnormal state. And here, the sickling is about a change of glutamic acid to valine in the beta chain. So simple amino acid change will completely change the hemoglobin from hemoglobin A to hemoglobin S. So glutamic acid is being replaced by valine through the mutation of codon 6, which is changing which controls an amino acid. So what happens? What happens is that you will have a hemoglobin S, and hemoglobin S has the characteristic under hypoxia to join the B and B1 and B2 chains. They combine under hypoxia, they cause binding. And this polymerization is detrimental to the RBC. How? Because this combination will lead to a hemoglobin which is firm, makes the RBC firm, and it causes early rupture or death, and it accumulates or adhere to each other, causing occlusion of the vessels. The normal RBC is concave, it has the ability of being flexible. It goes in small blood vessels, and it percolates through the tissues nicely, because it changes the shape. As the condition requires. But this is not a characteristic of the cell, which is called sickle cell. Sickle is, is an old cultivation instrument, very primitive. It's like a curve, a metal curve with wooden handle, with a wooden handle, and this is the curve is called the sickle, and this is in Arabic is called the manjal. This is why the anemia is called al-manjaliya, al-anemia al-manjaliya, or al-anemia al-hilaliya, because this is the sickle is rounded and it gives the hilal or crescent shape. This hemoglobin will the cells will become hard, they adhere to each other and they cause occlusion. So vaso-occlusion is the hallmark of pathophysiology of sickle cell disease. Hallmark, vaso-occlusion. If you go to the spleen, you get vaso-occlusion and sequestration. In the lungs, you get infarcts. And in the brain, you can get stroke. And in the bone marrow, if it is occluded, it can give dactylitis. So the vaso-occlusion is the essence of the whole pathology of pathophysiology. Historically, the first patient identified, maybe for the first time, to recognize the sickle cell disease in a dental student in 1910 in Grenada. Grenada is in South America or Latin America. And this dental student was discovered to have symptoms of sickle cell disease, and when the peripheral blood picture was looked, the RBCs were seen. So the hemoglobin also will cause, S-hemoglobin will cause dehydration of the cell. Dehydration of the cell, meaning, dry cell, which is less compatible with changing the shape, which is necessary for movement of the cells. So polymerization, which is the hallmark again of the vaso-occlusion, is brought up by hypoxia. And this is often can occur in the tissue, but because the RBCs are normal, there is no sequelae of that. Then if hemoglobin concentration is high, then there is more polarization. The baby, when he's born, he is born with hemoglobin F, what is called fetal hemoglobin. And fetal hemoglobin protects the baby when born with SS. But if there is fetal hemoglobin on board, then the baby will be protected against the symptoms of hemoglobin S. So that is in the first 3 months. But once hemoglobin F dries out or is getting decreased, then it is the symptoms of sickle cell disease becomes apparent, and that is after the first three months. So the white counts also contribute to this adhesive property of hemoglobin S. White count increases the inflammatory around the hemoglobin and increases the adhesiveness. Also platelets, higher platelets or coagulation will also increase the adhesiveness of the hemoglobin S disease. Okay, so this is the pathophysiology and hematology. This sickle cell appears in the peripheral blood picture, and there is a technique whereby you get sealing by wax around the cover of the slide, and then this will increase the degree of hypoxia, and the peripheral blood will show the sickle cell, the typical sickle cell anemia or sickle cell picture. But however, the diagnosis has to be ascertained and confirmed by electrophoresis, because hemoglobin A will have a certain way of travel and hemoglobin S has another certain way of travel. So electrophoresis will determine if there is hemoglobin S. There is another hemoglobin which is as bad as hemoglobin S, which is hemoglobin C. If hemoglobin C with hemoglobin S, it is co-herited, then you will have a hemoglobin SC, which behaves very much like hemoglobin S, or sickle cell disease, with no difference at all, not in the management and in the pathology. Okay, but if hemoglobin SC is more common in West Africa, and it behaves very much like hemoglobin SS. So we have hemoglobin SS, which is homozygous. We have hemoglobin SA, which is a carrier, and we have hemoglobin SC, which behaves very much like hemoglobin SS. So, what are the clinical consequences of hemoglobin SS? What is the hemoglobin, the sickle cell? What does it do? The polymerization of the sickle cell. What does of the RBCs containing the sickle cell? What does it do? It's primarily vaso-occlusion. Vaso-occlusion, which precipitates in very severe infarctions, pain, and pain is the hallmark of sickle cell disease. Pain is the hallmark of sickle cell disease. So it's an acute episodes of pains everywhere, particularly in the bones, in the lungs. Vaso-occlusion is will result in pain and destruction of the skin, giving you chronic ulcers. So the pain is on top of a chronic necrotic destruction of the tissue of the body. So it's not just an acute pain which resolves rapidly and the patient behaves normally. No, the pain, there is chronic process which is going on in the lungs and in other places, the bone and other places, whereby, at the end of the day, you have major destruction of the tissue. Just look, huge amount of symptoms and signs just resulting from one change of amino acid, glutamic being replaced by valine. The whole thing, this is very, very amazing in خلقناكم بأحسن تقويم. So, what are the symptomatology of this? We can put it under anemia. We can put it under acute chest syndrome. We can put it also under stroke. And then we can put it under chronic diseases of the skin and bone. So the acute stage it can occur with dactylitis, what is called dactylitis, is inflammation of the metacarpal and metatarsal bones. These are the bones, metacarpal here, all right, and metatarsal in the feet. And what happens is occlusion of the bone marrow. Infarction of the bone marrow will result in release of chemicals which will cause inflammation of the periosteum. The periosteum, and this causes inflammation of the periosteum covering this metatarsal, metacarpal bone, and causes very severe foot and hand and foot disease. Okay, because the hands will be so swollen, so painful, and it's a state of emergency. So that is as far as bone is concerned. But there is a process, chronic process that goes on in certain parts of the bones, especially the neck of femur and the ball of the femur, the ball of the femur and the acetabulum gets necrotic, avascular, and gradually the bone will lose its texture and becomes very necrotic, needing to have an operation. So there is one way of detecting these bones, and it's in the chronic form. Okay, anemia is hemolytic anemia. The sickle red cell survives only for 17 days. And if you remember that the RBC, the normal RBC, survives for 120 days. So it gets hemolyzed. So hemolysis is one part of the cause of anemia, and hemolysis will drop the hemoglobin and will cause bile salts or biliary stones in the gallbladder. Because if you have chronic state of bilirubin and bilirubin salts, then you can get stones in the gallbladder. So hemolysis is one of the main features of sickle cell disease. So anemia also can occur because of red cell aplasia, and this occurs through a virus which is common, which is parvovirus, and causes cell aplasia. Okay, there is one aspect of the anemia relates to spleen. Let us talk about what happens to us, the spleen in sickle cell disease. The spleen is enlarged because this is a hemopoietic tissue, but the spleen can sequestrate, what we call splenic sequestration. And sequestration here means that the veins of the spleen, which drives the blood from the spleen into the portal system, can be vaso-occluded. It can be vaso-occluded because of the polymerization of the RBCs, which we have alluded to. Okay, so once the spleen gets occluded, or the veins become occluded, there is very sudden enlargement of the spleen, very severe pain. And a matter of fact, this can be fatal, because if it is not treated rapidly, it can be fatal. And it's one of the causes of death or mortality due to sickle cell. So there is sudden pain, sudden enlargement of the spleen, and the spleen becomes so tender. But a state of hyposplenism occurs. And hyposplenism, the patient becomes very vulnerable to infection, especially pneumococcal and cyst encapsulated bacteria. There is increase of RBC, increase of platelets, which is and platelets, which can cause coagulation. Splenism can lead to death of the spleen, infarction, and later on a small volume spleen, like autosplenectomy. So the autosplenectomy can occur following sequestration of spleen, or can occur through repeated infarcts of the spleen. At the end of the day, the child may have no spleen functioning. It's no functioning. There is a tissue of spleen, but it's called hyposplenism. And generally, if you lose your spleen, or somebody loses his spleen, then it will be, it causes a hyposplenic syndrome, which the patient becomes very vulnerable to pneumococcal infection, and will be vulnerable to malaria infection. And patients who takes their spleen out should have a prophylactic penicillin routinely, and this also includes sickle cell disease patients, and should be vaccinated against pneumococcal infection. And in tropical Africa, where it's endemic with malaria, they should receive prophylaxis against malaria because they become very prone to infection with malaria. So that is sequestration of the spleen. Sequestration of the spleen. Just to repeat that there is vaso-occlusion of the splenic veins. Okay, sudden enlargement of the spleen becoming so painful and may be infarcted, and during this process, hyposplenism may occur, and then the sequence will be hyposplenism, which is dangerous because of the infection. Okay, then we have, we said anemia, we already dealt with anemia. We have the hyposplenism or the sequestration, the pain, the severe pain anywhere, especially the dactylitis can occur. The patient always become very ill, you know, he's jaundice, you know, he's anemic. Anemia is almost constant. And fatigability, the pain when recovers, become fatigued, and it's a state of chronic illness. Remember, just because one amino acid, glutamic acid, has been replaced by valine. There is a syndrome called acute pulmonary syndrome, and this is the major cause of mortality in sickle cell disease. Major cause of mortality in sickle cell disease. What happens? It's a syndrome. A syndrome is a collection of clinical picture or clinical signs put together. We cannot formulate a disease in that sense, but we can put it together as a syndrome. So it's an infiltrate on the chest X-ray, and this infiltrate is associated with cough, sneezing, cough, wheezing, expectoration, sputum, and hypoxia. This is syndrome because of vaso-occlusion within the lungs. It is increased by any reason of hypoxia, which will increase the vaso-occlusion. As we said, the one cause of sickling, one precipitating major cause of sickling is hypoxia. And previously, because of the airplane, we are not pressurized. Patients with sickle cell, when they go up in the air, they get a lot of crisis. But nowadays, all these modern airplanes are very well pressurized, and there is no danger with that. But hypoxia remains very important. Hypoxia can be decreased by enough hydration of the patients, enough oxygen. So what happens with acute syndrome, the acute pulmonary syndrome? The patient, there is infarcted, atelectatic lung, and the pain, the patient will become severely severely agonized with pain. So it's severe chest pain with a lot of symptoms and signs. This can be relieved by oxygen, and can be obviously relieved by pain, pain-killing factors, and then it can be relieved by what we call incentive spirometry. The spirometer is a handheld machine which when you blow, we know how the FEV1, which is forced expiratory volume, in the first second, again, is the vital capacity, which will tell us if the chest disease is restrictive or obstructive, but it will tell the lung functions. But here we have therapeutic, what we call therapeutic incentive spirometer. And this is halt hand, and the patient breathes gradually, teaches him how to get more oxygen, and that may settle or increase the oxygenation of the lungs. But this disease of acute pulmonary disease, acute chest disease, is very dangerous, and by and large, it is a major cause of death. So that is acute syndrome. And then the stroke. We have a stroke, again, vasocclusion, and in the stroke, these vessels will accumulate and then get adhered to themselves, and they cause a blockage. So stroke is always a cerebrovascular accident due to thrombotic or hemorrhage or embolization. Here, both hemorrhage and thrombosis are the likely one. In children, hemorrhage, because the blood supply in the brain in a child is very, very fast. And it is in thrombotic mainly in adults, thrombosis of the arterial vessels, and they cause hemiplegia, similar hemiplegia. And it is the commonest cause. Sickle cell is the commonest cause of hemiplegia in children. Obviously, low oxygen, dehydration, all that will increase the risk of dehydration, increases the risk of occlusion, okay, of thrombosis, and then it causes the hemiplegia. Here we have an indication of who is going to get more thrombotic stroke. Here we have the transcranial Doppler, the transcranial Doppler assessment of the velocity of the cerebral supply, the velocity of cerebral supply. And the figure is greater than 200, okay? If it is greater than 200, then the child is more prone to strokes. And here, the treatment, if it goes above 200, the treatment is blood transfusion. These are children who receive quite a lot of blood transfusion with some complications with the blood transfusion. But here, blood transfusion will relieve the chance or decrease the chance of stroke if it is the velocity, transcranial velocity, the Doppler is greater than 200. So stroke is, the treatment of stroke is blood transfusion. If you can increase the hypoxia, the oxygenation, and decrease the hypoxia, and then the patient should receive chronic care, because once he gets a hemiparesis or hemiplegia, then he's dependent on others where they can physiotherapy and rehabilitation and occupational therapy. Sickle cell disease, the management is multi-team dependent. Obviously, hematologists will be there, okay, for the treatment of the sickling, and we need an ophthalmologist because you will have an occlusion of the retinal veins, and you can get retinitis and blindness from the occlusion. You need also an orthopedic surgeon because of these infarcts in the bone marrow and the dactylitis. And clearly, if you have chronic avascular necrosis of the head of the femur, then an orthopedic surgeon is needed, maybe to have a replacement of the head, or it's an implant of another head or another joint completely. So we need orthopedic surgeon as well. We need dermatologists, because these patients can have damage of the skin and chronic ulcers. So this again needing, because of the avascularity of the skin in the area being occluded, then it becomes clear. They need infection and all the rest of it. So we need multiple team to help the patient with sickle cell. Okay, what is the outcome of disease of sickle cell in Africa and in other places where the blood transfusion is available, when care is more available versus Africa? You remember, this is medicine in Africa. Already the prevalence is very high in Africa. Africa produces 230,000 child a year with sickle cell disease. So that is a large number. And I think it is time to have clinics for sickle cell disease in many parts of, at least somewhere in each city, a major city of Africa. We used to have that in Sudan, in hospitals, children's hospitals. We have a dedicated clinic for sickle cell children. Okay, blood transfusion is very helpful. Blood transfusion is very helpful. We can have blood transfusion in the acute state, like stroke, or hemolysis if there is hemolysis and the anemia goes down below the 10 mark, 10 gram mark. Then blood transfusion, guarded blood transfusion can help. And in the acute chest syndrome, again, blood transfusion can help. Okay, so blood transfusion can be used either as a top up, meaning that there is anemia, there is acute episode of pain, we can give blood transfusion. Or in the chronic state, which is almost like exchange transfusion. And in the exchange transfusion, you take so much cells which are sickled and replaced by normal cells. And this obviously may tie up the patient during acute stage. Okay, so it's either a top-up transfusion or an exchange transfusion, which will help for some time. But transfusion is always attached with complications, all right? Cross-matching should be very perfect. And now we have extended cross-matching because in sickle cell disease, we already have what we call alloimmunization. That is to say, antibodies which are rising, alloimmunization, which is may cause some problems to the patient. So, extended transfusion will look into the very small antigens differences and exclude any transfusion, any blood, which is not 100% cross-matched. The kidneys can be affected by by sickling, particularly infection. As we said, infection is higher in patients with sickle cell because of the debilitating disease, because of the sequestration of the spleen, the autosplenectomy, and the hyposplenism, which occurs in terms of taking the spleen out, not only by surgery, by autosplenectomy, which meaning that it has been infarcted so many times that it shrunk into size and became non-functioning. That is the increased infection. So in the kidneys, you can have pyelonephritis, and because of the occlusion, you can have tubular necrosis. And this will lead to infection and then later may cause renal failure. So it's an important area to deal with. So patients with sickle cell should receive prophylactic penicillin, and prophylactic penicillin continuously has been shown to reduce mortality and morbidity. Secondly, is transfusion. The transfusion, which has to be guarded very well and given on demand or on regular basis. Transfusion. So it's but something you really care, especially in Africa, when HIV/AIDS and hepatitis B are carried by blood. Then you have to be extra careful to screen the blood cleanly before it's been transfused. So it's the picture is not all that flory. Children, the disease, if you read the books, deep books, the disease in children behaves slightly different from those who are adults, but by and large, it is a joint vaso-occlusive disease, okay, in adults or in children. The reproductive part is important because one of the problems is priapism. Priapism is thrombosis of the penile vessels and gives you permanent erection. It gives you permanent erection. And this is very painful. If you have a permanent erection, it's called priapism. And it doesn't go down except on surgery when the clots has been removed. And unfortunately, if that happens, the chances of being impotent or the patient being impotent is very high. More so, sickle cell disease will delay sexual development. So it's a disease which affects all the body, and it's been reported that psychological abnormalities or psychiatric abnormalities are commoner in diseases in patients with sickle cell disease. So in summary, it causes painful crisis on top of continuous or chronic damage to the tissues of the body, particularly CNS and lungs. So you'll have the crisis, acute crisis, which can be extremely painful, like dactylitis. You can have the priapism, which is again very painful. You have stroke. You have acute lung disease. You have retinopathy. You will have osteonecrosis, pain in the bones, osteonecrosis, an avascular head of the femur, and you will have splenic sequestration causing severe crisis. So pain, and most of these patients needing opiates or morphine to relieve the pain, and that is another issue. If these patients repeatedly come to the hospital receiving strong analgesia like pethidine and morphine, then they may go into it with addiction. So what is the treatment? The treatment is multi-team, okay, and try to prevent and try to rehabilitate the patient and vaccinate, and above all, to decrease the prevalence, is you should have counseling of any couple, antenatal counseling, all right? And this is done in areas where there is high prevalence, that the counseling. If you get a husband or a husband-to-be hemoglobin AS, and the mother or the the future wife is again AS, then the chances are very high to get out of them carriers, at least two, and one diseased, and one healthy. So you should advise, at least carrier could get married to a normal AA or hemoglobin A patient, a spouse, and then this will decrease the amount. But this is a social undertaking, and social acceptability is not very high in these cases. We need education. We need to cover the whole aspect of sickle cell into the general policies of the country, the general advice, and in patients, like Saudi Arabia, they have tried this counseling, and maybe that they have some success with it. But it is important. It's in families who have history of sickle cell has to be advised. It's up to them if they accept it or not. In Sudan, sickle cell disease is very common. It's common. And particularly in the west of Sudan, and the west of Sudan, okay, particularly certain tribes like Rizegat, Miseria, and some tribes there, like Taisha. These are subgroups of Rizegat and others. These have high degree of sickle cell. And one of the sons of the chief of one of these big tribes have been, as a friend, and during the TV program of Sahatak, he used to insist that we should talk more and more about sickle cell to educate the people or the tribes which have sickle cell disease. So the treatment is multi-team, treatment of reduction of crisis or painful crisis, vaccination in hyposplenism against pneumococci, penicillin therapy, anti-malarial therapy. All this will definitely decrease morbidity and mortality. And counseling, this is, if it is done, then we have to advise the couple before marriage, and long term, in maybe years to come, if this is being followed, the gene of the sickle cell may die. But I cannot see it happening very soon. So, are there any treatment to be given? The answer is yes. Simple ones like folic acid. Folic acid deficiency is common in sickle cell because of the hemopoiesis, increased hemopoiesis. And if you give folic acid, then that will help in the correction of anemia. And people like giving folic acid, maybe that it has another effect. But the drugs, specific drugs, should be used when the aim of the drug is maybe decrease hemoglobin S or increase hemoglobin F. As you remember, the children when are born with hemoglobin F, they have no symptoms of hemoglobin S. So the sickle cell disease does not appear in the first 3 months because of hemoglobin F. So if we have any way of increasing hemoglobin F, then that is another way of preventing people from sickle cell disease. Secondly, if there is a treatment which will help in decreasing hemoglobin S, then that is will be another drug which can be used. The drug which is commonly used is hydroxycarbamide. hydroxycarbamide, and it used to be hydroxyurea. It used to be called hydroxyurea. Now we are calling it hydroxycarbamide. And the essence of hydroxycarbamide, it increases, main action is increases hemoglobin F. And that will give you a better protection of against hemoglobin S. So it's a cheap drug. It can be used chronically all the time. Okay. Then we have to look into where to give blood transfusion and when to give blood transfusion and how much blood can we give. So that is hydroxycarbamide, and luckily it is very cheap, very cheap, and it can be used indefinitely to try and raise hemoglobin F. Okay, there is newer drugs now are used. Voxelotor is a VEXOLETOR, Voxelotor, and this is a drug which is can decrease the hemoglobin S somehow, okay, and reduce the vasoconstriction and reduce the varicose. And then you have monoclonal antibodies. Monoclonal antibodies like P-selectin, P for paper, P-selectin, or we can have L-glutamine. Okay, these are drugs which are now being used, but some of them are still in the process of testing. But to still have a reasonable drug, hydroxycarbamide, which can be used indefinitely, and folic acid as well. I have looked after some patients with sickle cell. I could remember them, even their names. Generally, it's from time to time, very long time in the hospital. They have a lot of infection, a lot of misery, and many of them, they lose their life. So it's a disease which we need to prevent. And the prevention is to decrease the gene circulation in the community. One aspect of hemoglobin S, it prevents against malaria. And paradoxically, this is saving the gene to persevere and exist in the community. Because if these patients get malaria, they get malaria, and I'm talking about sickle cell trait. They get malaria, they can be killed. They can be killed by malaria, and the gene will disappear. But it's just a scientific discussion, this one. So it prevents. So this is why we think that the gene has persisted in generations in Africa, because it protects against malaria. Okay, but once you have a disease, you have a hyposplenism, malaria could be increased. But for the carrier state, it's a blessing having an S hemoglobin, because it prevents against malaria. But that's a very high price to prevent malaria, to have hemoglobin S. That's just a intellectual thinking. Okay. So in conclusion, I would like to say that sickle cell disease is very common in Africa. It goes up to 25 to 30% of the population. That's quite a figure. And about 230,000 neonates are being born in Africa with sickle cell disease. It's a disease which is due to an abnormal hemoglobin just because of mutation of a single gene, codon 6, which will affect the amino acids from glutamic to valine. Okay, and the hemoglobin becomes, very hard. It has polymerization between B1 and B2 chains, and becomes harder. It becomes, the RBCs becomes inelastic, and it curves, giving you the sickle shape of the RBCs, and it cannot negotiate its way through small arteries, through small veins, and through small capillaries. This is why it causes vaso-occlusion, and the whole pathology is dependent on presence of vaso-occlusion. Next time we will hope to talk about thalassemia, which is again maybe prevalent in certain parts of Africa, and we may talk about eosinophilia, because in the world of worms, particularly tissue worms, eosinophilia is important, but that will be for later. I would like to thank you for being with me in this lecture, and we hope to see you next time. Thank you very much indeed.